Welcoming everyone to join our free NCLEX review session today, and we'll be tackling on the gastrointestinal concepts today. So let's get started with a Q&A. Now, here's the question. A 55-year-old male presents to the ED with complaints of vomiting, bright red blood, dizziness, and abdominal distension. He reports generalized weakness for the past week. His past medication or medical history includes liver cirrhosis secondary to chronic alcohol use, portal hypertension, and hepatic encephalopathy. He is currently taking spironolactone, furosemide, and lactulose. On assessment, his blood pressure is 88/50 mmHg, heart rate is 120 beats per minute, and he is diaphoretic and pale. Laboratory results show a hemoglobin level of 7 grams per DL, elevated liver enzymes, and INR of 1.7. He denies any recent NSAID use, peptic ulcer disease, or anticoagulation therapy. He is on the liver transplant list. Now, I really want you to recall the concept about the GI disturbances. Now, your task right now is to fill in the diagram by selecting the potential condition, 2 risk factors, and 2 actions. Now, what would be the correct potential condition around this time? Well, the correct answer for this potential condition would be the upper GI bleeding related to esophageal varices, and this is a common complication of portal hypertension due to the liver cirrhosis, especially in patients with a history of chronic alcohol use. Now, the patient symptoms that we are seeing in the scenario actually included the vomiting of bright red blood, also hypotension, and tachycardia, which indicate hypovolemic shock secondary to the upper GI bleed. And he also has a history of liver disease and portal hypertension, which also increase the likelihood of variceal rupture and bleeding. Now, the others, such as the Mallory-Weiss tear, those are that is incorrect, because that is a small tear, or let's say a laceration in the esophagus, and this is caused by severe vomiting or retching. Now, if you had answered letter, or if you'd answered upper, or let's say the peptic ulcer disease rather, that is also incorrect, because this is a condition that is because of the patient's history with a lack of NSAID use and also denial of peptic ulcer history. And there's also absence of chronic epigastric pain, and this makes this diagnosis less likely. Have the gastric cancer as one of the options. That is also incorrect, because we know that the patient's symptoms point more towards the acute and severe bleeding source, which is a characteristic of the variceal bleeding rather than a slow bleed commonly seen in gastric cancer. Now, what are the 2 risk factors that you should be selecting in this scenario? Well, you have the following risk factors: obesity, GERD, H. pylori, portal hypertension. You also have the chronic alcohol use. Now, the correct answer for, or answers for, the risk factors are the following. What could have possibly caused the patient to have the upper GI bleeding related to the esophageal varices? Well, the correct answer, one of those, would be the portal hypertension, as we know that the esophageal varices is actually going to be aggravated by this condition. And again, this is a complication to the cirrhosis of the liver. This will increase the pressure in the portal venous system, which can cause the development of the esophageal varices. And the increasing pressure there can cause these varices to rupture. Now, another risk factor that you should select here would be the chronic alcohol use. And this is a known major cause of liver cirrhosis, which can lead to the portal hypertension as well. Now, why are we not selecting the other options, such as the H. pylori? We know that H. pylori is the leading cause of peptic ulcer disease, but it is not related to esophageal varices. And there's no association, as we are looking back into the case scenario. It is not directly associated here. Now, for the other options, we have the GERD. We know that GERD can cause the esophagitis, right? But it does not lead to esophageal varices. And that condition can primarily involve a lower esophageal uh, bleeding. I mean, not a lower esophageal bleeding, but it also involves the lower esophagus, but it is unrelated to the portal hypertension, rather, or to the variceal formation. And we also have the other option here, which is obesity. It is a risk factor for other GI disturbances like GERD or non-alcoholic fatty liver disease, but it is not a direct risk factor to the esophageal varices. Now, looking into the action to take, what are the two interventions that you should select here? So your task here is to select those interventions that can point or that can treat the patient's upper GI bleeding. So one of those would be the administration of blood transfusion, or prepare to administer blood transfusion, as we know that the patient has a drop in the hemoglobin level of 7 grams per deciliter. Okay. With that significant low hemoglobin level, blood transfusion is very necessary to restore the circulating blood volume and also to improve the oxygen delivery to the tissues. Now, the next intervention that you should select here is the administration of the octreotide. What is this medication? Well, this is a somatostatin analog that is used to decrease the portal blood flow, and it can also reduce the pressure in the esophageal varices, and it can also control the bleeding, and it is a first-line drug therapy in managing the variceal bleeding. Now, if you had answered the insertion of the nasogastric tube or lavage, that is going to be so controversial. There is a higher risk of actually worsening the bleeding from the varices this time. And this is not something that is routinely done for esophageal varices. And as much as possible, it should be avoided unless absolutely necessary. Now, if you'd answered administer omeprazole, we know that this is a medication called, it is categorized under the proton pump inhibitor. It is used to treat peptic ulcer disease or GERD by reducing the stomach acid, but it is not effective in treating esophageal variceal bleeding. As we know that the bleeding is due to the high portal pressure. It is not caused by the acid erosion. Now, if you answered administer metoclopramide, this is a drug that is a prokinetic agent. It is used to promote gastric emptying, typically used for gastroparesis or nausea and vomiting, but it does not have a role in treating in a patient with esophageal varices to control the bleeding. It does not. If you answered, I don't think that, I probably had mentioned everything here. So I think that's it. So again, with this scenario, think about the patient developing that upper GI bleeding related to esophageal varices. So to wrap this up, your two risk factors are the portal hypertension, you got the chronic alcohol use, and the two nursing interventions here are to prepare for blood transfusion and administer octreotide. Let's do the next question this time. All right. A 55-year-old male client has massive bleeding from esophageal varices. What should the nurse and the care team prioritize for this client? Is it A, relieve the client's anxiety, B, maintain a patent airway, or C, replace fluids, D, control bleeding? Of course, you're already seeing the answer there. It's letter B. The rationale for having that letter B is because when the patient presents the esophageal bleeding, this can actually cause a possible aspiration of the GI contents. And so we want to make sure that this is not compromised. So your goal here around this time is to make sure that you are going to look for any signs of airway compromise. Okay. This can really lead to respiratory distress. I know. So What you're going to need to do here is to basically position the client appropriately and make sure you also have a available suction that's needed to help prevent the aspiration. Now, if you had answered letter A, relieve the client's anxiety, that would not be a priority intervention in the immediate phase. This is something that you can do at a later time. What our goal here is to address the ABC. So remember your airway, breathing, and circulation prioritization. Now, the other interventions that can be possibly done as soon as you selected the first option, which is maintaining patent airway, would be the controlling of hemorrhage and also replacement of fluids. Hang on a sec. Let me just check real quick on a slide. Okay. All right. All right, almost there. Okay, let's proceed to the next question. What should a patient with a cirrhosis be closely monitored for when receiving diuretics to manage ascites? And you can select all that apply here. Okay. All right. Again, the question is, what should a patient with cirrhosis be closely monitored for when receiving diuretics to manage ascites? Select all that apply. A, gastrointestinal bleeding. B, low potassium or hypokalemia. We have C, kidney function. D, concerns about body image. Or E, high risk of bleeding. Okay, take note about the case. We are dealing with a patient who has cirrhosis and you're administering furosemide, or let's say a diuretic, I should say. And the reason is to manage the patient's ascites. So you have to select more than one answer this time. So there are two correct answers in this question. Those are letters B and letter C. We know that the diuretics can actually deplete the electrolytes. For example, we got the potassium, right? It can affect the level of that potassium. It can lead to hypokalemia and other electrolytes as well. And another thing that you need to be doing here this time is to also monitor for the kidney function. You can take a look into the creatinine level and also the blood urea nitrogen, as we know that the diuretic can really cause an elevation of these values as well. If you had answered gastrointestinal bleeding and also body image concerns or increased high risk of bleeding, these three options are not linked to diuretic use. Good for you guys for answering letters B and C. Wonderful. Next question we have, what early sign of hepatic encephalopathy should the nurse be aware of? A, shows asterixis. B, becomes unconscious. C, develops increasing oliguria. And D, experiences difficulty with computational tasks. Let me reread. What early sign of hepatic encephalopathy should the nurse be aware of? A, shows asterixis. B, becomes unconscious. C, develops increasing oliguria. And D, experiences difficulty with computational tasks. All right. The correct answer here would be letter D, experiences difficulty with computational tasks. This is the early indicator of hepatic encephalopathy. This is what we call as grade 1. The other grade 1 manifestations of hepatic encephalopathy would be shorter attention span. There could be personality changes. There will be shorter term memory. There's going to be confusion that is mild. There's also depression and lack of coordination. If you answered letter A, shows asterixis, this is considered grade 2. Okay. If you answered letter B, becomes unconscious, this is grade 4. And then if you answered letter C, it's not categorized Actually, that is more related to a hepatorenal syndrome, not hepatic encephalopathy. So the correct answer this time is letter D. Experiences difficulty with computational tasks. Let's have another question. So this is a drag and drop type of question. A 62-year-old male patient with a history of cirrhosis presents to the ED with hematemesis after experiencing severe abdominal pain. The patient is diaphoretic and appears lethargic. Abdomen is distended with ascites noted. Spider angiomas are visible on the chest, and the nurse suspects a rupture of esophageal varices. So take a look into the lab results here. We got the WBC of 10,000 per cubic millimeter. We got hemoglobin of 8.5 grams per deciliter, BUN of 28 milligrams per DL, creatinine of 1.0 milligrams per DL, albumin of 4.2 grams per deciliter, INR of 5.1, glucose of 200 milligrams per DL. And we've got the following vital signs: temperature of 98.9 Fahrenheit, pulse rate of 110 beats per minute. We have a respiratory rate of 22 cycles per minute, and blood pressure of 70 over 40 mmHg. Now, your task this time is to complete the following statement. The client is at risk for developing blank as evidenced by blank and blank and blank. So we got the three columns here. So for the first blank, you're going to select from this column, and we have for the second blank, this is the column that you will be selecting for option 2, and for the third and fourth blanks, you're going to select from the third column. Again, the client is at risk for developing blank as evidenced by blank, blank, and blank. So basically, to the patient's scenario, what do you think would be the risk for this patient? Well, this is actually going to be the hypovolemic shock. We know that the patient is experiencing significant blood loss because of the rupture of the esophageal varices, which can lead to the hypovolemic shock. And the patient's lethargy, where is that? Okay, that, along with the diaphoresis, these are signs of inadequate perfusion. So that supports the hypovolemic shock. Why not hepatic encephalopathy? Why not? Well, we know that this is characterized by the confusion, right? Or mental status, which is associated with accumulation of toxins from liver failure. We know that this patient has liver disease, but in the scenario, there's no sign of any confusion or altered or any other manifestations that could be related to the confusion. So we're not selecting that one. So if you'd answered the sepsis, this is also incorrect. We know that sepsis is characterized by an infection, right? And also systemic inflammatory response. And this patient does not show any signs of infection. And if you answered acute respiratory distress, that is also incorrect, because ARDS is associated with severe lung injury, or let's say inflammation that can lead to respiratory failure. And that scenario here does not really indicate any of those. And if you answered acute kidney injury, we know that AKI can result from reduction in the perfusion, right? Especially during a hypovolemic shock. But this is not the one that we're looking for around this time. So the blank, the second blank, which is the evidence, would be the blood pressure of 70 over 40 mmHg. Okay, that is what we are seeing in our patient's vital signs. The low blood pressure is a critical indicator of the hypovolemic shock because of the significant blood loss, and it signifies that there is inadequate circulation and also perfusion to the vital organs. Now, the third blank here would be the hemoglobin of 8.5. So you're going to be selecting on the third column. We know that we have that already in our scenario, 8.5 hemoglobin. Okay. And we are not going to be selecting the other supporting evidence. They are not going to really point to the hypovolemic shock. And then the last answer would be the INR of 5.1. That is so elevated. Take a look at that value in the INR. So with that, an elevation of the INR basically suggests that there is an impairment of the liver function, and this is going to place the patient at a high risk of bleeding due to the coagulopathy. And so this is one of the contributory factors in the patient's bleeding as well. All right, let's go into the next question. A cirrhotic patient with hepatic encephalopathy is prescribed lactulose, rifaximin, proton pump inhibitor, and the patient's family asks why the laxative is needed. What is the nurse's best response? A, it helps reduce pressure in the portal vein, or B, it clears blood from the GI tract, or C, it traps ammonia and removes it through bowel, and D, it decreases. Oh, congratulations, Mary. Very good to hear. Wow. Congratulations. I'm so glad. I'm so glad. So letter D, it decreases bacteria to lower ammonia production. So I want you to recall of what we spoke about yesterday on the case of cirrhosis. And we are going to look back into the question. Again, there are prescriptions of lactulose, there's a lactulose, rifaximin, proton pump inhibitor, and the family is asking why the patient is using a laxative. So the reason for that laxative use is to actually trap ammonia, and it removes it from the bowel through allowing the body to excrete it through the feces. So that is the correct answer. If you answered letter A, it helps reduce pressure in the portal vein. The lactulose doesn't do that. This is going to be acted upon by a beta blocker. Let's say a propranolol, which is indicated to lower the portal venous pressure. It can reduce the risk of esophageal variceal bleeding. If you answered letter D, it decreases bacteria to lower ammonia production. This is not acted upon by the rifaximin, but rather not lactulose, but rather the rifaximin. It is an anti-infective or an antibiotic that will decrease the count of bacteria in the gut. And if you answered letter B, it clears blood from the GI tract. None of these medications can actually do that. However, we know that the proton pump inhibitor can reduce the stomach acid, but it does not eliminate the blood, or it doesn't clear blood from the GI tract. All right, let's move to the next question. A 62-year-old male patient with a history of cirrhosis presents to the ED with profuse hematemesis due to ruptured esophageal varices. The patient is diaphoretic, lethargic, and has a blood pressure of 90/60 mmHg. So for each provider order and nursing action listed below, indicate whether it is indicated or not indicated for the management of active bleeding from esophageal varices during the immediate phase. Again, for each provider order and nursing action listed below, indicate whether it is indicated or not indicated. And this is going to point out regarding the patient's issue about the active bleeding from the esophageal varices. So we have our first row, administer 0.9% sodium chloride IV bolus. What do you think about that? This is going to be indicated. We know that our patient here will be requiring some volume resuscitation to help stabilize the patient's blood pressure. And we know that with this condition, it can really cause a significant blood loss. So the correct answer here is indicated. If you answered place the patient in supine position, of course, you're not going to let this happen, right? What you're going to do instead here is to place the patient in a semi-Fowler's or high Fowler's position to prevent aspiration, and it can also improve the respiratory function. It can also reduce pressure on the esophageal varices. Now, if you are going to place the patient into supine, this can increase the risk of aspiration, especially if the patient is vomiting. What about the third row? Administer octreotide IV, and this was already mentioned earlier, right? What we're going to do with that is that is going to be an indicated provider order. Okay, this is the drug of choice to treat the active variceal bleeding, and we know that it can decrease the portal flow, blood flow, and it will reduce the portal pressure as well. So it will help control the bleeding from the esophageal varices. What about this one? Upper endoscopy and band ligation. Do you think this is correct, or is this indicated or not indicated? This is also indicated. This is the definitive treatment in controlling the active esophageal variceal bleeding. And we know that the band ligation during the endoscopy can help control the hemorrhage, and this will also prevent further bleeding episodes. Okay. Now, let's have monitor vital signs every 15 minutes. What do you think about this one? Is it indicated or not indicated? Well, that is indicated. We know that frequent monitoring of the vital signs is essential in assessing the patient's hemodynamic stability, and this can also detect early signs of hypovolemic shock from ongoing blood loss. Now, what about administer packed red blood cells, or PRBC? Is this indicated or not indicated? Well, packed red blood cell transfusion, this will be also necessary to replace the blood lost due to the active bleeding. And so we need to maintain adequate hemoglobin and hematocrit levels in order to ensure oxygen delivery to the body tissues. Now, what about encourage oral fluid intake? Is this going to be indicated or not indicated? Your patient is having perfuse hematemesis. Are you going to encourage oral fluid intake? Of course, around this time, it is not indicated. During the active bleeding, the patient should be kept NPO, or nothing by mouth, to prevent aspirations and also to prevent further complication. And we know that resuming the oral intake around this time could also worsen the bleeding, or it can also cause choking in case the patient will keep vomiting. Now, lastly, we have provide patient education about the condition. Well, during the immediate phase, this is not appropriate or not indicated. You can do this once the patient is more stabilized, when there is more readiness. We know that education is important, but not a priority during the active bleeding. What you should focus around this time would be to stabilize the patient, and we can provide the education after the bleeding has been controlled, and again, when everything has been stabilized. All right. Look back into the stem of the question. Management of active bleeding from esophageal varices during the immediate phase. All right, let's do another question. A patient with cirrhosis and esophageal varices resistant to treatment undergoes splenorenal shunt. What should the nurse anticipate the patient to experience? Is it A, increased survival rate, or B, lower serum ammonia levels, C, enhanced nutrient metabolism, or D, better hemodynamic function and renal perfusion? We're talking about splenorenal shunt placement, and the patient is having that one. Okay, so what would the nurse anticipate once they have this splenorenal shunt? Well, the correct answer for this question is letter D. It is going to improve the hemodynamic function and the renal perfusion. It will manage the portal hypertension. It can divert the blood from the portal vein to the renal vein. So it will reduce the pressure in the portal system. So it can really decrease the risk of the variceal bleeding, and it can also improve the cardiac output and also the blood supply to the kidneys and other major organs. If you answered letter A, increased survival rate, according to statistics, it's not actually doing that. It's not going to improve the survival rate. The same thing with enhancing nutrient metabolism. It doesn't really extend life or improve liver function. If you answered letter B, lower serum ammonia levels, well, according to this the statistics regarding splenorenal shunt, or even just the procedure itself, it does not decrease the ammonia level, because what is actually being done in this procedure is it's because the blood is being bypassed. Okay, it's not going to go back into the liver for detoxification. So there's actually a higher chance that the patient will have an elevation of the ammonia. So it doesn't really treat that component or that complication. All right, so that's it for today. I hope that you're learning some about our questions regarding the GI issues, focusing on the esophageal varices or bleeding and also cirrhosis. I hope to see you again in the next session, and I will see you then. Thank you and have a great day. Bye-bye.